this question say the nurse is reading a healthcare provider progress note. Progress note about what? About the client record. And read that the healthcare provider has documented insensible fluid loss approximately 800 ml. The nurse make a notation that insensible fluid loss occurred through which type of excretion, right? So some of the fluid loss we can see and some kind of fluid we do not see, right? The fluid loss, what we do not see, it is called insensible fluid loss. So the key word is here, the insensible fluid loss we said, right? Insensible fluid loss occur through the skin or intragumental system, or it is can possible go through the lungs, skin or lungs here. But sensible fluid loss occur through the, the person aware about this, like urination, pee. So here they said, number one, here, urine output, but urine output we can see, right? It is not insensible. Wound drainage, we can see. Intragumentary output, we do not see. So it is insensible. Gastrointestinal tract, definitely we can see. Like diarrhea, we can see it is not insensible. So let me see their explanation. Insensible losses may occur without the person's awareness, and insensible loss occur daily through the skin and lungs. And insensible losses and sensible loss are those which person be aware. Means urination, wound drainage, or gastrointestinal tract losses like diarrhea. So to compare, I want to tell you something details about the fluid intake and fluid output. Here we are just going to compare some important point related fluid intake and output. So the total amount of fluid we supposed to intake, some books said 1,500 to 2,500 over 24 hours. So many sources told it would be 3 liter or 3,000 ml per day or 24 hours. NCLEX board, if you give 3 liter, they will not give you 2,500 ml. Any one they can give you. So usually how much fluid we take and how much we output, it would be equal, same amount. So output would be 1,500 to 2,500 ml over 24 hours, or 3 liter. 3 liter equal to 3,000 ml per day. The fluid, what we do not see, we are not aware, we call insensible losses. Sensible fluid loss occur through the intragumental system like skin or lungs. The amount 500 to 1000 ml per day. So normal fluid for colostomy or enema loss occur 500 to 1000 ml. The amniotic fluid, normal pregnant mother content 500 ml to 1000 ml. Why suddenly I am going to talk amniotic fluid or colostomy fluid? Because there are similarities. When you put together, it would be easy to remember, and you can use it during the NCLEX board exam. And how much blood loss during normal vaginal delivery or normal the cesarean section. So the vaginal delivery, the normal blood loss occur 500 to 1000 ml. In case of cesarean section, loss occur 1000. But vaginal delivery, blood loss occur 500 to 1000. It is very important for NCLEX board. Also, you should remember the minimum urine output would be 30 ml per hour. So, urine output, right, is 30 ml per hour. It's a normal. So how much 24-hour per day? 30 multiply 24. Important for NCLEX board. In this question, we can say the healthcare provider assigned to care for the group of client. On review the client, the medical record, the nurse determine that which client is the most likely at the risk of fluid volume deficit. So fluid volume deficit, this is the keyword, right? And opposite of this, we called the fluid volume excrete or excess, right? So what are the condition patient develop the fluid volume deficit? If patient have any medical condition where the too much fluid loss. So first of all, we said a client with ileostomy. So GIT fluid loss, like nausea, like vomiting or diarrhea. Same as ileostomy, is one way of fluid loss. Second option, a client with a heart failure. Third one, a client with a long-term steroid use, or a client receiving frequent wound irrigation. So number 4, frequent wound irrigation chance to develop fluid volume excrete. Heart failure patient always develop fluid overload. So patient develop edema. Also, the person who use a steroid for a long time, they chance to develop fluid volume overload. Except number 1, which one can chance to loss of the fluid? So what is their explanation? They said A fluid volume deficit occurs when the fluid intake is not sufficient to meet the fluid need by the body. The cause of fluid volume deficit include vomiting, diarrhea, or condition that cause increase the respiration or increase urine output. Insufficient intravenous fluid replacement or draining fistula or presence of ileostomy or colostomy. This is the cause of fluid volume deficit. On the other hand, the client with a heart failure or long-term steroid therapy or the patient who have wound and they undergo frequent wound irrigation, most are the risks of fluid volume excess or overload, right? So if I see my patient has a fluid volume deficit, what are the nursing care? So always we measurement the body weight, also provide fluid replacement. Otherwise, patient undergo to the shock and also report the urine output. Usually the person who undergo the fluid volume deficit, their urine output supposed to less than 30 ml per hour. We always notify healthcare provider. On the other hand, if my patient has a fluid volume overload or excess, in that scenario, we also measurement the body weight every day, also, but restrict the fluid and sodium if the fluid volume overload, right? So now, let me explain something more. Here we are going to compare and contrast the fluid volume deficit and fluid volume overload. What would be the nursing care? So if your patient have fluid volume deficit, we measurement every day their body weight. Also provide the fluid replacement. When you report to the healthcare provider, if we say urine output is less than 30 ml per hour, and also we assessment for any kind of risk factor like prevention the fall. On the other hand, if patient have a fluid volume overload or excess as as deficit, measurement that daily body weight is important. It indicates the retention or deficit. Also restrict the fluid and restrict the sodium intake, or fluid or sodium intake should be as prescribed or as ordered. Administer oxygen and diuretics. And diuretics expel out excess fluid from the body and reduce the edema. And also prevent the skin breakdown. Important for NCLEX board exam. Question here, the nurse caring for a client who has been receiving intravenous diuretics and also suspected that the client is experiencing a fluid volume deficit. Examiner, make this question easy for you to write fluid volume deficit. So if the body demand and body needs or the supply or intake is not same, patient develop the fluid volume deficit. Which assessment finding would the nurse note the client with this condition? So what are the symptoms of fluid volume deficit? If you know, you can answer this question. So the person who have fluid volume deficit, they develop the tachycardia, tachypnea, or they develop hypotension, weak pulse, they easily get fatigue or weakness or thirsty, right? So if you see the mucous membrane, it would be dry as well. Or patient develop oliguria. Also decrease the skin tegor, right? So let me read the question here. The first one, weight loss and poor skin tracker. Definitely it is the sign of fluid volume deficit. Lung congestion increase the heart rate. So weak pulse is a sign of fluid volume deficit. But lung congestion and increase the pulse rate here, or decrease the hematocrit, or increase the urine output. This is the sign of fluid overload. So in case of fluid volume deficit, we found hematocrit level go up, but it is decrease. What is the sign of fluid volume overload? Increase the respiration and increase the blood pressure. If you have excess fluid, overload of the fluid, blood volume increase and blood pressure go up and patient develop hypertension. So also it is not an answer. The most appropriate answer is the fluid loss, body weight loss, and poor skin tracker. This is the sign of fluid volume deficit because patient develop dehydration. So a fluid volume deficit occurs when the fluid intake is not sufficient to meet the fluid needs of the body. Assessment findings in a client with a fluid volume deficit include increase the respiration or heart rate, decrease the central venous pressure, also body weight loss, poor skin tracker, sign of dehydration, dry mucous membrane, and decrease urine volume, but increase the specific gravity of the urine, increase hematocrit, lab velos, and also altered level of consciousness or but lung congestion, increased urine output, increased blood pressure, all are the sign of fluid volume overload. But the similarities, both cases, patient develop tachycardia and tachypnea. Like fluid volume deficit, patient develop tachycardia, tachypnea, but hypotension. If the patient have a fluid volume overload, patient develop tachycardia, tachypnea, but hypertension. So let me compare and contrast the lab values in case of fluid volume overload and fluid volume deficit. So what are the lab result? During the fluid volume deficit, if you check the hematocrit or serum osmolarity or urine specific gravity or hypernatremia, all of them will be increased. Means increase the hematocrit, increase the serum osmolarity, increase the urine specific gravity. It is more than 1.03, and also hypernatremia, and it is more than 145 milliequivalent per liter. On the other hand, in case of the fluid volume overload or excess, the hematocrit, serum osmolarity, urine specific gravity, and serum electrolyte, BUN, and creatinine, all of them will be decreased. So lab value decrease hematocrit, decrease the serum osmolarity, decrease the urine specific gravity. Usually it is less than 1.01. Also decrease the electrolyte, decrease blood urea nitrogen and serum creatinine level. So if you read, compare and contrast, it would be easy to remember during the exam time. So now here, next question we go. The question here, on review the client medical record, the nurse determined that which client is at the risk for fluid volume exceed or overload. There are 4 options. Which patient chance to develop fluid volume overload? The client taking diuretics. So if your patient take the diuretics, they go for the urine output or go for the pee. So no chance to develop fluid volume overload. The client with ileostomy. Ileostomy is a way to fluid loss, about 500 to 1000 fluid loss during the ileostomy, GIT fluid loss. No way to fluid overload. The client who require intermittent gastrointestinal suction is another reason of fluid volume over deficit, vomiting, diarrhea, suction. Number 4, the client with a kidney disease, also 12-year history of diabetic. So there are 2 diseases, kidney not function and patient have a diabetic mellitus. So if your kidney does not work well, kidney fail to expel out the fluid or waste product, in that scenario, the patient have a chance to develop fluid volume overload, right? So what is their rationale? The fluid volume excrete is also known as overhydration or fluid overload and occur when fluid intake or fluid retention exceed the fluid need of the body. The cause of fluid volume overload include decrease the renal function or kidney function, heart failure, use of hypertonic fluid, or excessive irrigation of wound or body cavity, or also excessive ingestion of sodium. So again, I said in case of fluid excess or overload, if you examine your patient, we found tachycardia, tachypnea, but hypertension, bounding pulse, body weight gain, shortness of breath, edema, and jugular vein distension. So kidney not functioning, kidney failure is one of the important cause of fluid overload. What next? Which client is at the risk for development of the potassium level 5.5 milliequivalent? So the normal potassium level 3.5 to 5.0. So if it is 5.5 means patient have hyperkalemia. So examiner asking out of 4 patients who have a chance of develop hyperkalemia, the client with colitis is the GIT problem. The client with a Cushing syndrome, or the client who have overusing laxatives, and the client who has sustained the traumatic burn. So first of all, the major cause of hyperkalemia, major cause I said, uncontrolled diabetic or diabetic ketoacidosis or metabolic acidosis, salt substitute, kidney failure patient, or if the patient take the medication called spironolactone, they have a chance to, or traumatic burn patient have a chance to develop the hyperkalemia. On the other hand, they said colitis or GI losses or some diuretics or skin loss, vomiting, all can cause hypokalemia. So out of 4 options, the most chance, I said here, the client who would sustain the traumatic burn patient, right, have a chance of develop hyperkalemia because potassium shifting occur in case of the traumatic burn. This is the option we choose to develop hyperkalemia. So what is their explanation? The normal potassium level 3.5 to 5, the serum potassium level higher than 5 indicate hyperkalemia. The client who experiencing cellular shifting of potassium in early stage of massive cell destruction like trauma, burn, sepsis, or metabolic or respiratory acidosis at the risks of develop hyperkalemia. So this is the causes who have a chance of develop hyperkalemia. Another cause I want to add here, renal failure or potassium sparing diuretics or high potassium intake or excessive use of salt substitute can cause increase the potassium level in the blood. The client with a Cushing syndrome or colitis and the client who has been overusing laxatives are at the chance of develop hypokalemia. But the Cushing syndrome not only chance of develop hypokalemia, they also chance of develop hypernatremia. Like here we said the traumatic burn patient have a chance of develop hyperkalemia, but burn patient also chance of develop hypernatremia. So go next. Question here, the nurse is caring for a client with a heart failure. Which sign and symptom could indicate the fluid overload? Select all. So if you know the sign and symptom of fluid volume overload, it would be easy to answer, right? So first one, they said bounding pulses. So as I told you, tachycardia, tachypnea, hypertension, and bounding pulse is a sign of fluid volume overload or excrete. Difficulty of breathing. So when fluid volume overload, the fluid is go inside my lungs and causes the congestion. And when patient develop the effusion, definitely develop the shortness of breath or dyspnea. It is the good choice. And increase the urine output. So I said increase urine output is not a good choice. So presence of depending edema, presence of depending. So when fluid is overload, the patient develop the urine output as well. Edema develop is one of the sign of fluid volume overload as well, right? So imagine a patient have a renal failure. In case of renal failure, it's not mandatory, but kidney will not functioning well, right? So no question about the urine output here. And also the neck vein distended, especially jugular vein distended occur. It is another good choice for the patient who have chance to develop fluid volume overload, right? So what is their explanation? Let me read it first. To care of the client with heart failure and fluid volume indicate monitoring the bounding pulses, difficult the breathing, neck being distension in the upright position, depending edema develop. So increase the urine output is not associated with the heart failure. So in this question, we see two keywords. One is the patient has a heart failure and patient has a chance of fluid volume overload. So this said last here, increase the urine output are not associated with heart failure and fluid overload. And what next? The question here, the nurse is performing assessment on a client admitted to the hospital with a diagnosis of dehydration. Which assessment finding should the nurse expect to note? So it is very important to know the sign and symptom of dehydration. Dehydration means the less fluid intake, right? First of all, bradycardia. So bradycardia is not a sign of dehydration. Dehydration leads to the complication. What complication? Dehydration decrease the blood volume. When blood volume decrease, patient develop hypotension or blood pressure go down, right? When blood pressure go down, it leads to the develop the shock, right? And this is called hypovolemic shock. The patient who undergo to the shock, they have a common sign of tachycardia, tachypnea, not a bradycardia, right? Elevated blood pressure never, because blood volume reduce, blood pressure reduce, and develop the shock. And if you do not treat the shock, patient will die, right? So how you correct it? Give them IV fluid and correct the hypovolemia. So if the patient have a hypovolemia or shock, they easily get confused. So their mental function will be altered. Level of consciousness will be altered. So change the mental status is a very good choice. Bilateral crackles in the lungs. So is because of dehydration? No way. If the fluid volume overload, fluid go inside the lungs and congestion is occur, and patient develop the added sound called crackles in case of fluid volume overload, not for the dehydration, right? So only one option we can choose here is number 3. So let go. What their explanation? The client with a dehydration is likely to be lethargic and also complain of headache. The client would also exhibit the weight loss, sunken eye, poor skin trigger, flat neck, and also peripheral vein, tachycardia, and low blood pressure. So the client who is dehydrated would not have bilateral crackles in the lungs. So what is the sign of dehydration? It is super important for our NCLEX board exam. Weight loss, sunken eye, poor skin trigger, flat neck, and peripheral pain. Also, tachycardia, tachypnea, and also low blood pressure, we call hypotension. And patient also develop very weak pulse. Easily they get fatigue, weakness, thirsty, dry mucous membrane. Also urine output will go down. We call it oliguria. And decrease the capillary refill. Every one is symptoms of dehydration. Question here, the nurse is caring for a client with a diagnosis of dehydration, and the client is receiving IV fluid. Which assessment finding would indicate the nurse that the dehydration remain unresolved, but still the dehydration is there? So question about the dehydration, and then treatment of dehydration, they giving the IV fluid, right? IV fluid for the management. But they said there are out of 4, which one indicate the dehydration remain unresolved? First one here, the oral temperature 98.8. So this is the normal temperature basically, right? Don't waste your time. The urine specific gravity 1.043. So urine specific, if my patient has a dehydration, the urine specific gravity would be increased. But when it will be correct, urine specific gravity will be normal. So basically, the urine specific gravity are 1.010 to 1.30. So let me write it 1.0 to 1.10 to 1.030. This is a normal urine specific gravity. Some book write 1.005. But this 1.04, so it is more than normal. So when the concentration reduce, concentration of the water or fluid reduce, specific gravity go up. When excess fluid, that time specific gravity will be go down, right? So here I said, when urine specific gravity is 1, it indicates patient are not get appropriate treatment, right? In normal lab value in dehydration, urine specific gravity should be more than 1.03, and it is happening still there, right? But in case of excess or overload urine specific gravity must be less than 1.010. Urine output, that is the pale yellow. So urine color is a pale yellow. It is nothing abnormal. Straw yellow is normal color. Blood pressure is 120/80. It is a normal blood pressure. It also does not indicate any abnormalities. So only number 2 is the choice. So here, so what is their explanation? The client who is dehydrated will have a urine specific gravity greater than 1.030, and value for urine specific gravity are 1.005 to 1.30. The body temperature is 98.8 degrees Fahrenheit or 37.1 degrees Celsius are normal almost, and also blood pressure 120/80 also the normal. So what they said, this indicator, so specific gravity is an indicator here, and it indicates patient dehydration remain unresolved. Question here, the client treated for a episode of hypothermia. So question about the hypothermia here, and being discharged to the home. The nurse determined that the client need to clarification of discharge instruction if the client state to need to perform which action. So out of 4, which one is not correct for hypothermia management? We need to re-educate the patient, then say goodbye and go home. So increase the fluid intake, definitely. During the hypothermia, we tell them to take enough fluid. Nothing wrong, it is good. Also resume full activity of level. So you are sick, you need to time to recover, and patient is hypothermic. They need rest. They need time to adapt. So you have to tell your patient it is too early to go for the full activities, right? Stay in the cool environment, definitely, because your patient is a hyperthermic. Monitor voiding for adequacy of urine output. So urine input and output measurement is super important for your patient. What is their explanation? So discharge instruction for the client when diagnose the hypothermia. The education would be included how to prevent the heat related disorder, increase the fluid intake, also self-monitoring of wording and maintain input-output chart, and also importance of stay in a cool environment or take the rest.